It's estimated that about 2 billion people worldwide are infected with Mycobacterium tuberculosis, often just shortened to tuberculosis or simply TB. 2 billion is a ton of people, but even though they're infected, that doesn't mean that all these people have symptoms. The vast majority, about 90 to 95%, aren't even aware that they're infected. And this is because usually the immune system can contain it, such that it's not able to multiply. It often remains latent or dormant, as opposed to active, which usually causes symptoms and can be spread to others. If the host's immune system becomes debilitated at some point down the road, like with AIDS or some other illness, or as a person grows older, it can be allowed to reactivate, or basically wake up and become very serious, especially if it spreads throughout the body. Mycobacteria are an interesting bunch. They're slender, rod-shaped, and need oxygen to survive. In other words, they're strict aerobes. They've got an unusually waxy cell wall, which is mainly a result of production of mycolic acid. Because of this waxy cell wall, they're acid-fast, meaning that they can hold on to a dye in spite of being exposed to alcohol, leaving it bright red colored when a Ziehl-Neelsen stain is used. The wall also makes them incredibly hardy, and allows them to resist weak disinfectants and survive on dry surfaces for months at a time. Now, Mycobacterium tuberculosis is usually transmitted via inhalation, which is how they gain entry into the lungs. Now, we breathe in all sorts of virus and bacteria all the time, but we've got defenses that take care of most of them. For one, air that we breathe in is turbulent in the upper airways, and drives most bacteria against mucus, which is then cleared pretty quickly. Ultimately though, TB can avoid the mucus traps and make its way to the deep airways and alveoli, where we have macrophages that eat up foreign cells, digest, and destroy them. With TB, they recognize foreign proteins on their cell surface and phagocytize them, or essentially package them into a space called a phagosome. With most cases, the macrophage then fuses the phagosome with a lysosome, which has hydrolytic enzymes that can pretty much break down any biochemical molecule. TB is tricky though, and once inside the macrophage, they produce a protein that inhibits this fusion, which allows the mycobacterium to survive. It doesn't just survive though, it proliferates and creates a localized infection. At this point, somebody has developed primary tuberculosis, which means that they have signs of infection soon after being exposed to TB. Even though it sounds bad, most people at this stage are actually asymptomatic, or maybe have a mild flu-like illness. About 3 weeks after initial infection, cell-mediated immunity kicks in, and immune cells surround the site of TB infection, creating a granuloma, essentially an attempt to wall off the bacteria and prevent it from spreading. The tissue inside the middle dies as a result, a process referred to as caseous necrosis, which means cheese-like necrosis, since the dead tissue is soft, white, and looks kind of like cheese. This area is known as a gone focus. TB also gets to hilar lymph nodes, either carried over by immune cells through the lymph or by direct extension of the gone focus infection, and causes caseation there as well. And together, this caseating tissue and associated lymph node make up the characteristic gone complex. Gone complexes are usually subpleural and occur in the lower lobes of the lungs. The tissue that's encapsulated by the granuloma undergoes fibrosis and often calcification, producing scar tissue that can be seen on X-ray. This calcified gone complex is called a Ranke complex. In some cases, although a scar is left over, the mycobacteria is killed off by the immune system, and that's the end of that. In other cases, even though they're walled off, they remain viable, and are therefore still alive, but they're just dormant. If and when a person's immune system becomes compromised, like with AIDS or with aging, the gone focus can become reactivated, and the infection can spread to either one or both upper lobes of the lungs. It's thought that this is because oxygenation is greatest in these areas, and TB, being an aerobe, prefers areas of greater oxygenation. Since they were previously exposed, the immune system's memory T cells quickly release cytokines to try and control the new outbreak, which forms more areas of caseous necrosis. This time though, it tends to cavitate, or form cavities, which can allow the bacteria to disseminate, or spread through airways and lymphatic channels to other parts of the lungs, which can cause bronchopneumonia. But it can also spread via the vascular system, and infect almost every other tissue in the body, called systemic miliary TB. When TB spreads to other tissues, it causes complications related to the organ affected. Kidneys are commonly affected, resulting in sterile pyuria, or high levels of white blood cells in the urine. It might also spread to the meninges of the brain, causing meningitis. the lumbar vertebrae, causing Pott disease, the adrenal glands causing Addison's disease, the liver causing hepatitis, and the cervical lymph nodes causing lymphadenitis in the neck, also known as scrofula. Testing for TB often starts with a purified protein derivative, or PPD intradermal skin test, sometimes known as a tuberculin skin test, MAN2 test, or simply TB test. With this test, tuberculin is injected between layers of the dermis. Tuberculin is a component of the bacteria, and if a person has previously been exposed to TB, the immune system reacts to the tuberculin and produces a small, localized reaction within 48 to 72 hours. If the reaction creates a large enough area of induration, rather than just redness, it's considered to be a positive test. Positive tuberculin tests simply mean that the patient's been exposed at some point to TB. It does not differentiate between active and latent disease. As an alternative to tuberculin skin tests, there are also interferon gamma release assays, or IGRAs, which look for evidence in the blood of previous exposure to TB proteins. Since this one's a blood test, you do not need to show up again to have the test read like you do with a PPD. Also, the IGRA is more specific to TB rather than other types of mycobacterial infections, and is unlikely to be positive as a result of having BCG vaccine in the past, a vaccine that protects against TB. And this is a pretty useful feature of IGRAs, since BCG vaccine is given to many children around the world to prevent disseminated TB. After doing a screen test with PPD or IGRA, anyone with a positive result typically gets a chest X-ray to look for signs of active TB disease. In patients with symptoms like fevers, night sweats, weight loss, and coughing up blood, or hemoptysis, it's important to collect samples from either the sputum or via bronchoalveolar lavage, which is where the bronchoscope is inserted through the mouth or nose into the lungs. Fluid is squirted, and then the fluid is collected. These samples can get sent to the lab for staining, culture, and PCR to look for evidence of Mycobacterium tuberculosis. Treatment of latent TB infection typically involves using a single drug for a prolonged period of time. The most common approach is isoniazid for 9 months. Treatment of active TB disease is typically done with different combinations of anti-TB antibiotics like isoniazid, rifampin, ethambutol, and pyrazinamide, which results in patients being non-infectious to others usually within a few weeks. Until that point, though, patients can spread TB to others, and it's typically adults with reactivated TB that are the most infectious. As a result, patients are typically kept in negative pressure rooms, and visitors are asked to wear protective N95 masks that can't filter out oil aerosols, N for not resistant to oil, but can filter out at least 95% of other aerosols, in this case TB. Even after patients are no longer contagious, they're typically kept on multiple medications for many months to be sure the bacteria are destroyed, usually with direct observed therapy, or DOT, where somebody watches and confirms that you're taking the medication. Additionally, there's an enormous worry about new drug-resistant strains of TB that are causing infections in various parts of the world. You might hear of MDR-TB, or multi-drug-resistant TB, or even XDR-TB, which is extremely drug-resistant TB, which is incredibly hard to treat because they don't die in the presence of our usual antibiotics. The bottom line is to get an effective treatment. It's super important to make sure that the drugs being used will work against the specific strain of TB, that multiple medications are used together to prevent drug resistance from developing, and that medications are used for the entire course of therapy so that all of the Mycobacterium tuberculosis is killed off. Recently, the US Food and Drug Administration has approved a breakthrough medication for XDR-TB called pretomanid. According to recent studies, a combination of pretomanid, bedaquiline, and linezolid has been effective for almost 90% of XDR-TB cases. As an added bonus, this combination therapy can be taken orally and is also very well tolerated compared with other XDR-TB drug regimens. Alright, as a quick recap, tuberculosis, or TB, is an infection caused by Mycobacterium tuberculosis that mainly affects the lungs. 3 weeks after the primary infection, the immune system tries to contain the infection created by a granuloma, and the tissue in the middle undergoes caseous necrosis, resulting in an area called a gone focus. TB also extends to nearby hilar lymph nodes, causing caseous necrosis there as well. The gone focus plus the affected lymph node makes up the characteristic gone complex. If the immune system becomes compromised, like with AIDS or older age, the gone focus can reactivate, and the infection can spread to one or both upper lobes of the lungs, where it forms cavities. From cavities, bacteria can disseminate to other parts of the lungs, causing bronchopneumonia, but it can also spread through the vascular system and infect almost every tissue in the body, which is called systemic miliary TB. Testing for TB starts with a PPD intradermal skin test, or with an IgRA blood test, and a chest x-ray can identify signs of active TB disease. In patients with fevers, night sweats, weight loss, and hemoptysis, a sputum sample can be stained, cultured, and PCR can be done to look for Mycobacterium tuberculosis. Treatment of active TB includes a combination of antibiotics, given for several months, and special regimens are used for MDR-TB and XDR-TB.
Mycobacterium avium complex, or MAC, includes 3 species: Mycobacterium avium, Mycobacterium chimera, and Mycobacterium intracellulare. MAC is the most common non-tuberculous mycobacteria, or NTM. The 3 different species of MAC are difficult to differentiate and cause the same spectrum of diseases, so they're often grouped together. MAC is very different from Mycobacterium tuberculosis. MAC lung infection is a chronic disease, often present for several years prior to diagnosis. It typically has a more indolent course and can be difficult to eradicate, with frequent recurrences after completing long courses of treatment. In addition, in immunocompromised individuals, MAC can become disseminated, affecting organs other than the lungs, and can cause lymphadenitis. MAC are non-motile, facultative intracellular bacteria, which means they can survive both inside and outside the cell. They're also aerobic, which means they need oxygen to survive. They have a high content of mycolic acid in their cell wall, which makes them waxy, hydrophobic, and impermeable to routine stain such as gram stain. So, they need special staining methods to be visualized, such as Ziehl-Neelsen staining, which is able to penetrate the waxy mycobacterial cell wall. So, the stain binds to the mycolic acid in the mycobacterial cell wall, and, after staining, an acidic decolorizing solution is applied which removes the red dye from the background cells, tissue fibers, and any organisms in the smear except mycobacteria, which retain the dye. And this is why they're called acid-fast, and they appear bright red on a blue background. Finally, MAC are slow-growing bacteria, and it typically takes them 10 to 21 days to grow on a medium called Lowenstein-Jensen. MAC are ubiquitous in soil and water, and they're thought to enter the body through inhalation. Once inside the body, they adhere to mucosal epithelial cells in the respiratory tract, and infect the macrophages that try to destroy them. Macrophages try to break down the MAC organisms inside an intracellular organelle called a lysosome, which contains digestive enzymes. However, MAC has unique antigenic lipids called glycopeptolipids, or GLP, which are found on the surface of the cell. These GLPs act as a protective barrier against lysosomal enzymes, allowing the bacteria to survive and multiply inside macrophages. When these mycobacteria multiply, they can cause inflammation, and this attracts more macrophages to the area. They try to quarantine the invaders by forming granulomas, and as these grow bigger, they form nodules. Eventually, this leads to nodular bronchiectasis, and the inflammation causes damage to the bronchi, which become scarred and dilated. The damaged bronchi have diminished mucociliary activity as well as decreased local immune function, and thereby lose their ability to move foreign material out of the lungs. So, mucus can collect in these dilated areas, making it the perfect environment for bacterial growth. Nodular bronchiectasis tends to develop slowly, but in some cases, the more aggressive and severe fibrocavitary disease occurs. Here, the mycobacteria invades the lung tissue, causing damage, severe fibrosis, and formation of cavities, much like tuberculosis. Since MAC are aerobic organisms, these cavities tend to be in the air-rich upper lobes of the lung. In rare cases, and almost universally in individuals with compromised immune systems, the infected macrophages can move into the lymphatics and spread the bacteria to other parts of the body, especially to the spleen, liver, and bone marrow. and from these organs they can spread to the bloodstream, causing disseminated disease. Now, MAC usually cause chronic lung infection in people who already have an underlying lung disease, such as chronic obstructive pulmonary disease, cystic fibrosis, or bronchiectasis. They can also affect people without a prior history of lung disease, especially in thin, middle-aged, or elderly females. People who are immunocompromised, like those with AIDS, who have a CD4 cell count below 50 cells per microliter, are more likely to develop disseminated infection. In young children, MAC can cause lymphadenitis, or swollen lymph nodes. Symptoms of pulmonary MAC infections include cough, fever, fatigue, weight loss, night sweats, shortness of breath, and recurrent respiratory infections. With disseminated MAC infections, there may be nonspecific symptoms such as fever, sweats, fatigue, and weight loss. On a physical exam, there can be hepatomegaly, or an enlarged liver, jaundice, or yellow pigmentation of the skin and mucous membranes, and lymphadenopathy, which means swollen lymph nodes. Finally, with MAC lymphadenitis, there are usually swollen lymph nodes mainly on one side of the neck. Diagnosis is established by identifying MAC in the sputum using staining methods and culture. If disseminated infection is suspected, culture specimens should also include blood and urine. Also, with disseminated infection, a complete blood count shows anemia and occasionally pancytopenia due to bone marrow suppression. And liver function tests may show high transaminase and alkaline phosphatase levels. Now, to assess pulmonary involvement, a CT scan should be done, which may show evidence of bronchiectasis, tree in bud like nodular infiltrates, ground glass opacities, or cavities. Finally, in cases of MAC lymphadenitis, a lymph node biopsy should be done. For treatment of pulmonary and disseminated MAC infections, a combination of a macrolide, such as azithromycin or clarithromycin, plus ethambutol and a rifamycin, such as rifampin or rifabutin, is used. In more severe disease, an intravenous aminoglycoside may be used for limited duration. For those with refractory disease or whose organisms have developed macrolide resistance, the addition of inhaled amikacin or clofazimine can also be considered. For those with pulmonary disease, treatment should be continued for 12 months after establishing negative sputum cultures. In addition, attention should be placed on trying to limit environmental exposure to MAC from aerosolized water and soil in order to prevent disease recurrence, which can occur in up to 20 to 50% of individuals. Also, people with AIDS who have a CD4 count below 50 cells per microliter should receive prophylaxis with a macrolide. Treatment of MAC lymphadenitis is done by surgically excising the affected lymph nodes. Alright, as a quick recap, the Mycobacterium avium complex includes M. avium, M. intracellulare, and M. chimera. They're acid-fast bacilli, non-modal, facultative, intracellular aerobic bacteria. They infect lung macrophages and survive inside of them with the help of glycopeptolipids, or GLPs, causing 3 types of infections: pulmonary infection in people with or without underlying lung diseases, disseminated infection in people with AIDS, and lymphadenitis in children. Diagnosis is established by identifying the mycobacterium in sputum, blood, or urine samples, as well as through compatible imaging studies, such as a chest CT scan to assess for pulmonary involvement. Treatment regimens typically include a combination of a macrolide such as azithromycin or clarithromycin, plus ethambutol and rifampin for pulmonary and disseminated infections. In MAC lymphadenitis, the affected lymph nodes are surgically excised.
Mycobacterium leprae is a rod-shaped bacteria which was first discovered in 1873 by Hansen. Mycobacterium leprae is a non-tuberculosis mycobacteria, and it causes a disease called leprosy, or Hansen disease. In the US, the animal reservoir for Mycobacterium leprae are armadillos. Now, Mycobacterium leprae is an acid-fast bacillus, which means it's resistant to decolorization by acids, and it has a high content of mycolic acid in its cell wall, which makes it waxy, hydrophobic, and impermeable to routine stain like gram stain. So it needs special staining methods to be visualized, like Ziehl-Neelsen staining, which uses carbyl fuchsin combined with phenol, which is able to penetrate the waxy mycobacterial cell wall. So the stain binds to the mycolic acid in the mycobacterial cell wall, and after staining, an acid decolorization solution is applied, which removes the red dye from the background cells, tissue fibers, and any organisms in the smear except mycobacteria, which retains the dye. So Mycobacterium leprae appears bright red on the blue background. Other staining methods can be used, such as Kinune staining, in which the bacteria appear bright red on a green background, and fluorescence microscopy, using specific fluorescent dyes like aramine-rhodamine stain. Now, Mycobacterium leprae is an obligate intracellular microorganism, which means it can survive only inside cells, and it's an obligate aerobe, which means it can survive only in the presence of oxygen. Finally, Mycobacterium leprae grows best at cool temperatures, between 27 and 33 degrees Celsius, and it proliferates slowly, and it cannot be cultivated in vitro. Instead, it can be inoculated in 9-banded armadillos, which have a much lower body temperature than most mammals, and like humans, are susceptible to leprosy. Now, Mycobacterium leprae can enter the body through the lungs or broken skin. Once inside the body, it goes for regions in which the temperature is lower than the rest of the body, like the skin, peripheral nerves, and mucosa of the upper respiratory tract. So the bacteria goes for the Schwann cells of peripheral nerves. These cells wrap their plasma membrane around peripheral nerve axons, forming the myelin sheath. This is possible because of a virulence factor called phenolic glycolipid 1, or PGL1 for short, which attaches to a protein called laminin 2, which is found on the Schwann cells. Binding to Schwann cells induces demyelination, affecting transmission of electrical impulses through the nerve axon, and causing nerve injury. Additionally, Mycobacterium leprae can also infect skin macrophages. So the bacteria is ingested by macrophages and wrapped up in a vesicle called a phagosome, which would normally merge with another intracellular organelle called a lysosome. Inside the phagolysosome, the bacteria would normally be destroyed. But Mycobacterium leprae has the ability to inhibit the phagolysosomal fusion, which allows the bacteria to survive inside the macrophages and replicate there. Now, the host responds to leprosy through cell-mediated immunity via T helper cells. These cells help the activity of other immune cells by releasing T cell cytokines. And there are two types of T helper cells, Th1 and Th2. Depending on which T helper cells are involved in the immune response, there are two major forms of leprosy, lepromatous and tuberculoid. Now, in the lepromatous form, the infection induces a Th2 cell response, and Th2 cells secrete interleukin 4, interleukin 5, and interleukin 10. These molecules are cytokines, which means that they signal B cells to make antibodies against Mycobacterium leprae. So this is a type of humoral, antibody-based response. Now, this response is not effective in killing intracellular pathogens like Mycobacterium leprae, that can escape humoral immune mechanisms and replicate inside macrophages. So the inefficient immune response seen in the lepromatous form is sometimes also called a low cell-mediated immunity response. This leads to extensive skin involvement and symmetric nerve involvement, and the lepromatous form is also called multibacillary leprosy because of the large number of bacteria found in the lesions. On the other hand, which is tuberculoid form, the infection induces a Th1 response, and Th1 cells secrete interleukin 2 and interferon gamma. So interleukin 2 activates cytotoxic T cells, and interferon gamma activates macrophages and natural killers to produce chemicals that destroy ingested bacteria directly, leading to a cell-mediated response. This response is effective in destroying Mycobacterium leprae, so this immune response is sometimes also called a high cell-mediated immunity response. Hence, with the tuberculoid form, there's a limited number of skin lesions, and nerve involvement is usually asymmetric. This form is also called paucibacillary leprosy because of the low number of bacteria in the skin lesions. Alright, now risk factors for developing leprosy include close contact with infected individuals and armadillos. as well as older age and immunosuppressive states like diabetes, malignancy, or an underlying HIV infection. With the lepromatous form, there are numerous raised, poorly demarcated skin lesions that can be found on extensor surfaces of the extremities. Within these skin patches, there might be diminished sensation or a loss of sensation altogether. And overall, there's a loss of sensation in the limbs, with a glove and stocking distribution. There might also be paresthesias, which are abnormal dermal sensations like tingling or numbness in the hands or feet, lumps or swelling on the earlobes or face, which can result in a lion-like or leonine facies, and body hair loss, especially eyebrows and eyelashes. Worst case scenario, things progress towards gradual destruction of the extremities. So the nose might collapse due to nasal septum destruction, and fingers and toes might necrose and fall off. Yikes. With the lepromatous form, there can also be ocular involvement in the form of chronic uveitis, meaning the inflammation of the uvea, which is the pigmented layer of the eye. There might also be facial nerve paralysis that leads to leg ophthalmos, which is the inability to close the eyelids completely. This can result in corneal ulceration due to corneal exposure and eye drying. With the tuberculoid form, on the other hand, there are hypopigmented or reddish patches on the skin, which are rare and well demarcated, and nerve involvement is usually mild, but there can be tender, enlarged peripheral nerves. In late stages, there's weakness of the hands with claw fingers, and foot drop, which is the inability to lift the front of the foot. On the bright side, though, no fingers are falling off. Now, diagnosis can be done by identifying Mycobacterium leprae in a skin biopsy of an active lesion and examining it under a microscope. In the lepromatous form, there are lipid-laden macrophages called foam cells containing many acid-fast bacilli, while in the tuberculoid form, there are very few acid-fast bacilli and granulomas, which are collections of immune cells. Mycobacterium leprae can also be identified through PCR, which directly detects bacterial DNA. Finally, a lepramin skin test might be done to determine what type of leprosy a person has. This is when an extract of inactivated M. leprae is injected intradermally, and if an induration appears after 48 hours, it means that there's a cell-mediated immune response against the organism. So this test is negative in lepromatous form and positive in tuberculoid form. Treatment for leprosy is done with multi-drug therapy to prevent resistance. So the lepromatous form is treated with dapsone, rifampin, and clofazimine for 12 months, while the tuberculoid form is treated with dapsone and rifampin for 6 months. Alright, as a quick recap, Mycobacterium leprae is an acid-fast bacillus, obligate intracellular aerobe, which cannot be cultivated in vitro. It has the ability to infect Schwann cells and skin macrophages, and causes a disease called leprosy or Hansen disease. According to the type of cell-mediated immunity response, there are two major forms of leprosy: lepromatous, which is the result of Th2 cells, or low cell-mediated immunity, and tuberculoid, which is the result of Th1 cells, or high cell-mediated immunity. Diagnosis can be done by identifying Mycobacterium leprae in a skin biopsy with microscopy or PCR. Treatment is done with dapsone, rifampin, and clofazimine for the lepromatous form, and dapsone and rifampin for the tuberculoid form.